Dear dental colleagues, my name is Emanuele Clozza and I'm excited to share with you my first ever recorded webinar regarding full arch implant restorations. First of all, I would like to thank the Austin Bureau team for giving me the opportunity to discuss the current evolution from conventional protocols to fully digital innovations. The presentation is a summary of a course I have been running with Austin UK for the past few years. And more specifically, it is a result of a clinical experience developed over 1,400 full arch implant restoration completed since 2014, with 1,200 interim and definitive prostheses delivered with conventional methods, and more recently around 200 arches with fully digital protocols. Regardless the utilization of a conventional or a digital technique, the goals of a full arch implant restoration should be to achieve a long-lasting prosthesis, to obtain a predictable clinical outcome, minimize the patient morbidity, simplify the protocol, and reduce the number of visits, and reduce cost by minimizing consumable materials or avoiding costly remake. This is the presentation outline. I'll be covering the current shift from conventional techniques to digital protocols in complete arch implant restorations, specifically in planning the case, in carrying out the surgery, in taking the impressions, in fabricating an interim and definitive prosthesis, and in obtaining facial records. I'd like to begin first with planning a full arch implant restoration. Conventionally, we take pictures, we plan on a cast and then on a OPG, whereas digitally we now utilize intraoral scanning, smile design, and cone beam. Regardless of protocol you may want to adopt, these are the clinical record input that you must collect, which are medical dental history, photos, radiographs, impressions or intraoral scanning, shade assessment, and aesthetic assessment. In addition to that, you want to discuss with the patient the consent form, the medication post-surgery, and the sedation. A poor record input would lead to inevitably a poor interim prosthesis outcome, which means more appointments to correct the interim prosthesis, stress and frustration for everyone, for you, for your staff, and of course for the patient. This is the temporary prosthesis checklist. I'll first begin determining the center relation, followed by the vertical dimension. Then I move to the maxilla with aesthetic parameters, then with the occlusion, so with the mandible, and then implant captures and soft tissue capture. In this picture, so we see that first we start with the center relation, so achieving the relationship between the maxilla and the mandible, followed by the vertical dimension, and then the aesthetic and occlusion parameters, which are inside this red perimeter. In terms of aesthetic parameters, we want to achieve on the maxilla the midline, the occlusal plane, the incisor position of the teeth, the tooth shape and position, side and form, the buccal corridor. And when it comes to occlusion, or we want to assess in the mandible, the contact cos fossa, the overjet, the overbite, and the skeletal class. How to determine the vertical dimension? We have learned from school that there are some tests you want to run. So we have a Silverman. The range of the vertical dimension should be usually within 7 centimeters. We have a touch lip, facial appearance, and the corner lip. Traditionally, we used to plan the case on a panoramic X-ray, like in this case, you can see in the white lines. And then we then take intraoral pictures with occlusion and front views. And then you can see the case completed with the implants position where we were initially planned, and with the delivery of a final prosthesis hybrid restoration with a composite denture teeth and a titanium bar. Nowadays, it's a common practice to assess and report a CT scan, planning the case on digital diagnostic imaging software, or we can utilize a virtual planning software, like in this case, or more sophisticated ways with the integration of a CT scan with the intraoral scanning data. Let's now move on the surgery. Conventionally, we place the implant freehand or with a pilot drill guide, and with the digital innovation, we have now fully guided protocols that I'll be discussing later. We have witnessed in almost 60 years a remarkable evolution of the surgical protocols of full arch implant restorations, whereas in the past 5 years we have seen a more tremendous innovation of the restorative side in terms of workflow and materials. One of the most dramatic changes in implant dentistry was the acceptance of immediate loading as a available technique in 1990, with a reduced treatment time and increased patient acceptance. The marginal bone loss was comparable with non-loaded protocols, and most failures has been reported within 6 months of function. The advantages of immediate implantation are that it reduces number of clinical visits and surgical protocols, and less patient morbidity, enables the immediate restoration, immediate function, and possibly preserve alveolar bone dimensions. A concept that was introduced more than 20 years ago was the all-on-4, which provides edentulous patients or patients with failed dentition an interim restoration on 4 or 6 implants, which is immediately loaded on the same day, and that will be then converted into a definitive full arch prosthesis approximately 3 to 6 months after surgery. This is the anatomy of a typical all-on-4 case. We have the prosthesis, which is kept in place with the retaining screws on multi-unit abutments, and we have multi-unit screws, and then dental implants inserted into the jawbone. A question that always patients ask is how many implants, 4, 5 or 6? Systematic review reported comparable survival rate regardless the number of implants that are placed. Another important concept is the angle distant implants, and there's plenty of literature covering the subject, and a systematic review also reported favorable prognosis, short-term and long-term. There's a surgical advantage in placing implant angles, we're able to place longer implants in high-density bone volume, and we're able thereby to increase the AP spread. What is an AP spread? It is defined as the mesodistal distance between the most forward and most posterior implant. Typically, the critical implants in rehabilitation are the most forward and most posterior ones. Therefore, this justifies the elimination of intermediate fixtures. There's also a biologic advantage in increasing the AP spread, and we are able to avoid the sublingual glands, therefore minimizing the risk of peri-implant infection, inflammations around the most forward implants. There's also a prosthetic advantage because we're able to decrease the distal cantilevers. It is important to familiarize with the multi-unit abutments, which allow prosthetic reconstruction of the tilted implants. They usually come in a 17-degree inclination, and then they are used to bring the working platform to the proper occlusal orientation. And the complete sitting must be confirmed, usually with intraoperative radiographs. The abutment screw is torqued at 15-20 Newton centimeter, and also the abutment carrier allows us to check the position in relation to the opposing dentition, like in this case. So keeping the abutment carrier in place allows us to check the parallelism of the implants and also the position in relation to the opposing dentition. Without using the multi-unit abutments, things can be very, very complex, like in this case. The access hole could end up buccally. Therefore, we have to use previously cement retained solutions, which will make things extremely complex and lengthy, or that could lead to costly and sophisticated prosthetic solutions, or cement retained full arch implant restoration, which is not ideal because that could be difficult for the patient to maintain, and also could cause smell and plaque accumulation. It is important when placing the implant in angle position to familiarize with the neighboring anatomic structure. And also there are some certain techniques that we need to be conscious, and then we use the initial drill to guide us to avoid the lateral wall or the mental foramen. Right, now let's discuss the bone reduction or ablation. It allows us to removal of bony spiculae. We are able to then place the implants at the same level. We can flatten the area, which minimize the drill slipping, makes a narrow ridge into a wide one. By flattening, we can gain the space that is needed for the restorative components. And a flat surface is also easier for the patient for the maintenance. And also we can gain enough space for the hybrid prosthesis without compromising the vertical dimension. And we can hide also the transition line in a full smile. We also have available the malleable guide with some vertical markings that can be used to orient the drill angulation during the initial osteotome preparation. Then we have the denture 4U kit that also guide us with a correct proper angulation for the distal implants. And also the kit I really enjoy using is the bone expansion kit for unfavorable bone morphology. Let's look at this case where clinically there was a narrow residual ridge, and we are able to place regular implants by expanding the residual ridge. And then this is the delayed case, and then 2 months after, with exposure of the implants, we're able to place the multi-units and then restore the case. Another auxiliary method to deal with extremely atrophic arches is the designing a 3D printed model from a CT scan data, which give a sense of where the implant should be placed, and then sort of guide the surgeon before the procedure to select the right implants to be placed. As you can see here from the pre-op CT scan, the case was quite challenging, and a 3D printed model can basically help us to position the implant correctly and plan the right size of the implants. And then in this case we under-prepared the implant sites in order to minimize the implant fenestration or dehiscence. We can then fabricate also a 3D print surgical guide or a pilot drill guide, which basically fits onto the residual ridge, and then that allows to place the implants in a correct and ideal position, minimizing the bone fenestration and dehiscence. And nowadays we have fully guided surgery protocols available with the wine guide kit. So I'm going to look at this case, a maxillary arch FP1. So the technician is able to provide us with a planning scheme for each implant site, and then with some sleeves where we're going to be placing the drills and then the implants. This is a case I did with a lab in London, and it was all pre-planned, the position of the implants on the guide and also on the interim prosthesis. And this is the interim prosthesis converted on the same day, which then was fitted with a metal reinforcement. And this is a picture after 2 months of function. And then the interim prosthesis then is replaced by zirconia full arch definitive prosthesis approximately 3 months after. Another case I'd like to share with you is an FP1 stackable guided surgery case from the CB for the combing data. We're then able to merge them with the intraoral scanning data, which allows to virtually construct a stackable guide, and it is 3D printed, and also the interim prototypes is also designed on a day with some sleeves with some holes that allows for the correct implant placement. Let's begin first with the maxillary arch. So we have the stackable guide in place. Once that is positioned correctly, we then proceed with the extraction of the remaining teeth, followed by the placement of the immediate implants, and then the fit of the multi-units. Moving to the lower dentition, we first position the guide correctly, and then we extract the remaining dentition, and then we place the implants and the multi-unit abutments. Then we start with the provisionalization of the case with a conventional protocol. So first we place 2 titanium cylinders onto the multi-units, and then we stabilize it in a correct position, and then we continue to add the remaining cylinders. And once they're all blocked into the interim prosthesis, then the prosthesis is processed and cleaned and then polished. Same thing you can see here on the lower arch, where the resin is added by the technician, and then the prosthesis is then polished and then fitted on the same day. And then the result is adequate, as you can see in this case, with adequate occlusal. And then always take a post-operative OPG. You can see here we have few issues. One is the inadequate fit of the prosthesis on the maxillar. This is due to sometimes excessive pressure on the pontics. So what we have to do is to remove the prosthesis and then adjust the pressure and then reduce the fitting surface. And when we have a misfit of the multi-unit abutments, if the implant and the multi-abutment are stable, that can be either addressed on the day of surgery, or if we are tired, we can then do that just before taking the final impression. And then you can see here an X-ray, a control X-ray, full of the adjustment of the pressure on the upper prosthesis. And this is the case then finalized with a full arch zirconia restoration. And then this is the final restoration in place, and this is the case completed with a post-operative X-ray, and all the multi-units in this case are properly seated, and as well as the prosthesis. Right, now let's move to the topic of the impressions. Conventionally, we have what we call the analog impressions, and then nowadays with digital protocols we have intraoral scanning and also the integration of photogrammetry. We have the option of taking impression at a fixture level or at the multi-level, the multi-unit level. If we look at the literature, there's no difference between splinted polyether or PVS impression materials. So regarding impression material you want to use, there's no really much difference in terms of accuracy, as long as you use pattern resin for a jig. And also they recommend an open tray implant impression technique, which is much more accurate than a closed tray. To achieve a complete passivity of the definitive prosthesis, it is important to do a splinted open tray impression and possibly do a verification jig for the master cast. If we don't do that, we can end up in having marginal discrepancies, misfit of the titanium of the metal framework, which leads to plaque accumulation and screw loosening, and also screw fracture. I'm gonna start now first with a conventional full arch fixture level final impression. As you can see, in this case, no multi-unit abutment were utilized, so even removing an internal prosthesis could take several times. These are, some lengthy techniques that we used to adopt for full arch implant restoration at fixture level, and having a lab-made jig, and then doing different and several big trying visits to make sure that the prosthesis was passive and fit adequately. So the problem is that in this case that would require several visits, and also could be risky in terms of passive fit. Another way is to have a jig made by the dental lab, and then we can then stabilize it and in a patient mouth. Or when it comes to multi-level, multi-unit level impression, we can use the existing cast that was utilized for the temporary prosthesis and make a chair side verification jig, like in this case. This is the most frequent way to take the full arch final impression that I've always used when it comes to conventional protocols. So we've placed the impression copings on the multi-unit abutments, and then we create a chair side pattern resin jig. and making sure that it's not at the same level of the residual ridge. And then we use polyether impressions material for light body, and then we use a custom tray or an implant impression tray to take the final impression. A technique that has been also introduced is the stone verification device, which is gives us validation of the position of dental implants analogs on a definitive cast. We can also take an X-ray to confirm seating. And if the stone verification fractures, it means that the definitive cast the technician is working with is not accurate. So what we have to do is to reconnect the parts with some plaster of Paris, and then the technician will re-pour a new definitive cast. Let's now discuss the conventional way to fabricate an intended prosthesis. So we can achieve that extraorally, which means after surgery we take an implant impression, and then the technician will make a lab-made intended prosthesis. Or more practically is the pick-up technique, which is done typically with acrylic resin or with pattern resin. Let's look at this conventional case, an upper arch. So after surgery, we isolate the residual ridge with rubber dam, and then we place titanium cylinders, and we cover the access hole with some PTFE tape, and then we use a pickup denture to which is basically blocking to in the patient mouth, and then we use a metal reinforcement in this case, and then the technician will basically add acrylic around the titanium cylinders, and then we'll remove the pallet and then polish the prosthesis on the same day. And then, so this is basically the traditional way to fit intended prosthesis for FP3, whereas now also we have for FP1 in this case. So after surgery we place the pickup denture. We then block the titanium cylinders with some ivory acrylic, and then the technician then will basically process the prosthesis by creating the weight pontics and then polish the fitting surface. How about the introduction of intraoral scanning for full arch implant restoration? How reliable is in different steps for achieving the final restoration? We know that it's a predictable tool to utilize at the initial situation when we want to scan the dentition before surgery. We're not sure yet whether it's reliable for post-surgery scenarios when we place the implants and the scan bodies. As you can imagine, it's very challenging capturing a residual ridge post-surgery because of the blood, and then also the absence of any anatomical landmarks. It's quite easy to then capture the existing intended prosthesis, and that's reliable, but we don't know yet whether it is a reliable tool to scan for final impressions. And now what we should do is to look at the literature. If we have here a recent systematic review and meta-analysis that basically compare digital versus conventional implant impressions. This study included 1 clinical and 9 in vitro studies, and the conclusion are that the full arch digital impressions have similar accuracy as the conventional impression. Okay. If we look at this most recent study, which included 2 clinical and 10 in vitro studies. There are few factors that can influence the accuracy of intraoral scanning, and are the type of intraoral scanner, the scanning technique, the environmental conditions, the angle and distal between the implants, the material of the scan bodies that could also affect the accuracy of the intraoral scanning data. In my clinical experience, I think that intraoral scanning alone is not really reliable for complete arch implant impressions. Because what about scanning more than 4 implants? How about in post-surgery situations, and also in the mandibular arch? These are not always easy to achieve. So there has been auxiliary methods that have been introduced to obtain much more accurate implant impression for the fabrication of a prosthetic for a definitive prosthesis. So we have now, I summarize here what's been recently published. We have an introduction of the utilization of a CT scan, or a creation of a verification index, which then is scanned in the lab. We have a fabrication of a verification device, or a most recent reverse scan body technique, which relies on clinically passive fitting internal prosthesis. So perhaps a verification jig is still needed. We also additional methods, which are a geometric device. We have self-adhesive radiopaque fiducial markers, scannable impression pins, or anchor pins on the jawbone. And now, so all the techniques are being reported in literature. However, I think they have all limitations, and then because they're not really they need to be integrated into the virtually, whereas it's not really very convenient for the technician. We want to have a system that is basically already virtually in the software. Another thing is that it's extremely challenging to scan the mandible, because we have saliva, patient mobility, lack of landmarks, and the peripheral soft tissues, and such as cheek and tongue, can interfere with the scanning procedure. We have a reduced attack gingival, and that it could be bleeding post-surgery, especially when retracting the cheek. And the majority of publications really are showing only upper arch restorations. So what I've seen is that the photogrammetry overcomes all these challenges by capturing the exact position of the implants. So it is a digital auxiliary tool. The scan body have 3 target points, so the machine is able to detect accurately the target points on these 3 surfaces. And the systematic review, which assessed more than 20 articles, have suggested that the final prosthesis can have a successful fit with 10 to 150 micron in terms of precision, and then this tool is a valid and a reliable clinical tool for implant dentistry. Now I'd like to show you a step-by-step case which I've done and which is in publication. It is a combination of integration of intraoral scanning with photogrammetry to provide a full arch implant-supported interim and definitive prosthesis. Okay, so this is the preoperative situation. So we use the intraoral scanner to scan the remaining dentition. Then we fabricate the prototype pickup denture. On day of surgery, after extracting the teeth and placing the middle implants, we fit the multi-unit abutment. We suture the tissues. Then we use the intraoral scanner to scan the the upper arch with the scan bodies, and then also we scan the opposing dentition, and we then determine the bite virtually. We also scan the intaglio of the pickup denture, and the next step is to fit the scan bodies, the ICAM for the scan bodies, and then we utilize the ICAM machine to determine the exact position of the implants. Then with the software, we can then align this data. So we align the intraoral scanning data with the photogrammetry data, and to achieve a correct position of the implants into the soft tissue scans. That allows the technician to design and fabricate the interim prosthesis, which in this case is done on the same day, and then allows to the fabrication of an interim prosthesis 3D printed, which is done within a couple of hours, and is fitted on the same day. And then an X-ray of a control X has been taken to assess the fit of the at the multi-unit level, which reveals adequate fit. And then 3 months after, the interim prosthesis is taken off, and then we use again intraoral scanning to scan the tissue and the scan bodies. And now let's look again at the intraoral scanning sequence for the maxillary dentous arch. So first, we scan the interim prosthesis in place, then we scan the opposing arch. We take some virtual occlusal records. We fit then scan bodies onto the multi-units, and then we scan them, and then we align all the data and to achieve a virtual articulation of the existing situation. How we carry out the alignment? In this case, I use the MEDIS software. So this is the scan interim prosthesis in place, and I virtually trim the prosthesis, and then I rescan the residual ridge, and then we have in the same file merge the files, and then this is the scan body in place, and then now I'm able to obtain the virtual alignment articulation of the interim prosthesis and of the implant position. The technician then is able to design and fabricate the final definitive prosthesis, which is adequate in terms of occlusion, aesthetics, and also shows passive fit clinically and radiographically. Right, now let's discuss prosthesis. We have a conventional way to fabricate the interim and definitive prosthesis. And also, in terms of digital, we have now the introduction of CAD/CAM restorations. What are the full arch implant treatment options? We have FP1 with no pink, FP2 with long teeth, and FP3 with artificial gingiva. How I'm able to determine the prosthetic design is based on finance, age of the patient, remaining teeth, bone, periodontal disease caries, patient compliance, expectation, power function, occlusion, how much time the patient has, and also the pain as well, if the patient is able to go through this procedure or not. And based on this, I'm able to determine and suggest and recommend the right prosthetic design. FP1, this is the topic that I would like to discuss, and this is an example of a traditional FP1 prototype prosthesis, okay, which then is also metal reinforced. It is my preference when we're dealing with failed dentition to go for a complete implant prosthesis. The reason why, if the patient wants to have a fixed partial implant prosthesis because of the so it means that he wants to start with one zone and then years after move to the other side. That the treatment length could be quite long, and also that would require multiple visits. The aesthetic outcome is questionable, and patient will have to go through multiple surgical appointments, and also the cost is higher and the maintenance is not ideal. Whereas doing a complete arch solution is the treatment length usually is no more than 6 months. That nowadays requires 3 to 4 visits, and there's only one surgical appointment. We need to also be familiarized with the Pontic design, and there's a recent article that basically describes the Pontic design option that we have in implant dentistry. A sanitary hygienic Pontic, so means that there's a gap of around 2 mm, 1 mm between the fitting surface and the distal ridge. This is used mainly in mandibular full arch supported prosthesis, and it's easy for the patient to clean, to maintain. It's not really indicated in the maxilla because it might lead to phonetic problems due to the lack of seal. Next option is the ridge lap full saddle with a concave intaglio surface. This solution fulfill aesthetics, phonetics, and functional requirements, and the ridge lap material limits the ability for the patient to clean, which is not really recommended. We have also another option, which is the conical bullet, and it's easy to achieve for the clinician and for the lab technician. Reasonable good aesthetic outcome, fulfills aesthetic, phonetics, and functional requirements. There's a minimal contact surface with the residual alveolar ridge. We avoid soft tissue conditioning or augmentation procedure. The papilla volume is in the case reduced. We have a conical bullet option for FP3, which is the preferred design, and it fulfills aesthetics, phonetics, and functional requirement, and there's a minimal contact area with the alveolar ridge. And then we have a modified ridge lap partial saddle, which is not again not recommended because of the difficulty for the patient to clean the implants. And then typically for the FP1 solution, we have the ovate pontics with a convex design. We have a light pressure to the underlying soft tissues, and this gives an ideal aesthetic outcome. It fulfills phonetics and functional requirements. The papilla volume is preserved. This technique, however, requires bone grafting, soft tissue conditioning, or augmentation procedure. We have a large contact area with the alveolar ridge. It could cause inflammation if not well maintained. Conventionally, in terms of definitive prosthesis, we can have denture teeth on PMA metal framework or porcelain and metal framework. This is what we call the gold standard restoration for full arch implant restoration FP3, which is a heat cured PMA titanium hybrid definitive prosthesis, and have with this solution now long-term cases documented, and it works. It is a predictable option. Let's look at this case, patient with failed dentition. So we plan a full mouth implant restoration with FP3. This is the case at the final fit, and then 8 years after, patient came back for maintenance. You can see overall the prosthesis is adequate. We just observe some wearing of the denture teeth, but the bone levels remain the same. Another option is, which is more premium, is the porcelain titanium hybrid definitive prosthesis. And now let's focus on CAD/CAM prosthesis, and which can be achieved with subtractive methods, milling, with interim prosthesis or trying prototype prosthesis, zirconia or hybrid definitive prosthesis. And then also we have addictive methods now with 3D printing, which allows to fabricate mainly prototype pickup dentures and interim prosthesis. Okay, mill interim prosthesis. This is the a case that I've done recently. The only issue in this case is that it could take several hours to mill an interim prosthesis. So it means that the device could be fitted usually on the next day. We have a mill PMA interim prosthesis with cemented titanium cylinders, and now most recently we have mill prosthesis that are designed to fit directly into the multi-units, which reduce cost and simplify the process. We have also trying prototypes mill. Conventionally we used to have wax prototypes with denture teeth, whereas nowadays we have one piece mill prototypes with or without a waxed gingiva. Let's now move to the mill definitive prosthesis. Initially we used trailer bar and crystal ultra sleeve. And the reason why we started with that is that because we thought that trailer bar, which is a polymer matrix with glass fiber reinforcement, exhibits natural flex load parameters similar to the bone. And then on top of that we have crystal ultra, which is a translucent and aesthetically pleasant CAD/CAM material used for monolithic teeth, and it is a nanoceramic material. So we use that, and however we noticed that after just few years that could lead to complications with the titanium cylinders and the cementing from the prosthesis, and also a risk of fracture. So it's very important to have a metal framework, and this study basically assess which is the precision and which metal framework we should go for. The conclusion is that the major source of ill-fitting framework is inaccurate implant impressions. And whenever possible, always add a verification step to ensure a passive fit. And titanium and zirconia titanium implant reconstruction are extremely accurate, and whereas the fit of the cast alloy framework is not always reliable. I'm going to show you now a case I've done with the upper with the maxilla fitted with a cast alloy framework, whereas on the lower arch you can see is a mill titanium bar. And this is the just a picture of showing a chrome cobalt framework. And this is in a titanium framework CAD/CAM design, which can be have a smooth surface, or in this case with some indentation to improve retention. And what we usually do, we can try this bar and assess the fit clinically in the mouth, with or without the wax bridge on top of it. And the bar now can also be designed to fit the residual ridge as well, or can be covered completely by the acrylic. And this is a case of a typical hybrid prosthesis that I provide to my patients for FP3 solution, which is the mill PMA with a titanium bar. Next, let's look into mill zirconia definitive prosthesis. Like in this case, we have a pretau zirconia with excellent aesthetic outcomes, like in this case. And then we have a monolithic zirconia, and then we have more sophisticated now solution, which is the with a porcelain build up on a multi-layer zirconia. Looking at the literature, what is the clinical outcome of full arch fixed implant supported prosthesis? 17 clinical studies were reviewed in this systematic review, and the typical complication reported included minor chipping, titanium cylinder cementation of fracture, screw loosening, and wear of the opposing arch. The prosthetic, the survival rate of the prosthesis overall is extremely high, which is more than 88%. A typical complication that we can encounter when it comes to full arch zirconia restoration is the chipping of the tooth, and that's upsetting for the patient, and then will lead to inevitably a costly remake. Right, now let's talk now about the 3D printed technology, which initially has been adopted for fabricating study models or prototype pickup dentures, and most recently I'm utilizing to fabricate interim prosthesis on the same day. So we use this technique to fabricate prototype complete denture for the pickup, for the virtual pickup, or we can fabricate FP3 interim prosthesis on the same day, or FP1 prosthesis, which are designed to fit directly onto the multi-unit. If we look at the accuracy, a systematic review meta-analysis that's been published recently have assessed 3 clinical studies, and the conclusions that there's no significant difference between the mill or 3D printed temporary, and they both exhibit acceptable marginal fit. Of course, the 3D printing allows to fabricate the interim prosthesis on the same day, whereas with milling it might take 1 day to complete an interim prosthesis. I'm gonna now show some cases. So I'll start with the dual arch FP3. In this case we have after the full mouth extraction, we placed the implants, and then the temporary was done in a conventional way. After the healing of the soft tissues, 3 months after, we then take off the temporary, scan intraorally, scan the existing interim prosthesis, and then this is the digital workflow. So first we scan the tissue, then we use the photogrammetry to capture the exact position of the implants, and then we merge the files, and then we achieve we design and then fabricate the definitive prosthesis, and this is the control X-ray, which reveal an adequate fit and excellent marginal bone levels. Another case is a dual arch FP2. So this is then recommended for patients with history of severe periodontal disease. So we start with the preoperative intraoral scanning, and then after the extraction and after the placement of the implants, we scan again the jaw with the implant impressions and the pickup denture in place. So on a surgery day, we take the implant impression with photogrammetry and with the intraoral scanner, and then 3 months after we take another intraoral scanner on the healed tissue, and we use the data that was stored with the photogrammetry of the surgery, and we merge the data again to fabricate the definitive prosthesis. Just to now discuss the steps to design the interim prosthesis. So first we start with the pickup denture, which is done immediately after surgery, and then we design and fabricate on the same day an interim prosthesis. Due to the complexity of the case, we were not able to on the same day focus on the accurate design of the pontics, so we fit an interim prosthesis with almost a flattened fitting surface, and then the technician have enough time later to design a much more adequate FP2 with more well-defined pontics, and which is fitted 1 week after surgery. 3 months after, the existing interim prosthesis is scanned, and then we also scan the position of the implants and the heel bridge, which allows us to then design and fabricate the definitive prosthesis. In this case, is PMA with a metal framework. And also, we're also able to, nowadays with the intraoral scanning, to capture also the movements of the existing interim prosthesis, and also transfer that virtually, so then our technician is able to simulate the jaw movements. Now another case, which is a dual arch FP1, following the extractions and the bone grafting sockets and the placement of 4 implants per arch. Then we these are the steps for the pickup denture, which is then scanned and with this soft tissue as well. And then the next step is to capture the exact position of the implants with photogrammetry. And then here I have a video that shows how quick it is to scan the position of the implants. And then we start first with the calibration, and then intraorally, actually extraorally, we then scan can see here now how quick it is to determine the right position of the implants. And all this data then allows to fabricate the 3D printed interim prosthesis. This is the picture in right after surgery, and then 2 months after. Once the interim prosthesis is removed, then we scan the tissues, we scan and position the implant again with an intraoral scanner, and then all this information allows to fabricate the definitive prosthesis, which is made by a PMA and a metal framework. Now let's focus our discussion on facial records, which is conventionally done with Facebook transfers of photos, and then more recently with digital techniques with a facial scanner. So we have a Facebook transfers or pictures that allows to basically capture information for the face, and this is very important for aesthetic purpose and function. Also, the photos help us to it's a communication tool between us, the patient, and the technician, and then at a different stage of the final restoration. And you can see here in this case, if we're not careful, especially with the midline, it's a typical mistake that we made. If we're not able to determine the right position of the midline, that will lead to inaccurate final restoration and then possibly costly remakes. I'm going to show now a case where we're able to address the midline position virtually. So the patient was wearing an interim denture fitted onto the attachment on multi-units. The occlusion was stable, however the midline was not adequate, and also the occlusion plane needs to be adjusted. So what we've done is first we remove some of the implants, and then we place one more implant, and then we fit on the same day a prototype interim prosthesis. After the healing, then we scan the existing prosthesis, and then the opposing dentition and the bite, and then we used the intraoral scanner to scan the perioral tissues and the nose, and which is then superimposed with the intraoral scanning data. The next step is to obtain a facial scanning data, which is then merged with the intraoral scanning data. As you can see here, the current interim prosthesis is still not straight, and the midline is not adequate. Moreover, the teeth are not giving enough lip support for the patient. So what we do now is to utilize all the virtual data to redesign an FP3 definitive prosthesis, which will improve all the aesthetic parameters. And this is how it's designed virtually with the aid of the facial scanning data. And then you can see now how the definitive prosthesis has been adequately designed, and then it is right in the midline is adequate, right in the middle, and also with adequate display of the dentition. Next, another case, the integration again of face scanner in a full mouth rehabilitation. So the patient with interim prostheses, which were done conventionally. So the interim prostheses are scanned. Next, we scan the dentulous arches and then the scan body, and then we merge the intraoral scanning data with photogrammetry. Once the intraoral scanning data and the photogrammetry data complete, then we scan the perioral tissues and the nose, and then we scan the face. We begin first designing the definitive prosthesis based on the position of the interim prosthesis. Then we merge the existing interim prosthesis with the face scanning data. And then what we can do also virtually is to improve the occlusal plane digitally. And then here I can show you a video that basically integrates the intraoral scanning with a face scanner. And you can see here how we can assess virtually the position of the existing interim prosthesis, and then we can proceed with the design of the definitive prosthesis with improving the aesthetics, the occlusal plane, and also the midline if necessary, and the dentition display. Again, see here where we virtually improving the occlusal plane. And once we are satisfied with that, and also we can assess the jaw movement virtually in the face scanning data in different views: occlusal and frontal view, lateral view. And also lateral movements of the definitive prosthesis. And then the follow step is to design the metal framework, and then also design the multi-layer upper restoration. So in this case, the upper restoration was multi-layer zirconia with a ceramic veneering, whereas on the lower arch we opted for a conventional, we opted for an FP3. And this is the final restoration done by Luca Dondi in Italy, and that's the final outcome with adequate fit showed on the post-operative X-ray. Another case that I like to show, which is the last one, is the complete digital workflow for full mouth implant rehabilitation in just 4 visits within 2 weeks. So we have a patient with limited bone, and then with a dentulous arch upper and lower. So on the first appointment we proceed with the surgery. We place the implants, and then we fit the multi-units. As you can see here, on the upper arch the bone was slightly limited, so we used the asset kit to do the bone expansion that allows to place the implant without damaging the residual ridge, and also increasing the stability of the implant fixtures. We then proceed to see the multi-unit abutments on the same day, and then first we scan the soft tissue and then the scan bodies. Then we use a photogrammetry to capture the position of the implants. The second appointment, 4 days after surgery, we determine the center gradation, the vertical dimension, we assess the shade, and then we take some photos, and which being then sent to the technician to assess the midline. Third visit, which is 10 days, just 10 days after surgery, we can try the prototypes in a patient mouth. In this case, we have to do some minor adjustments, and then we record the bite. Then we transfer all the data virtually, and then we proceed with the design of the metal framework and of the definitive prosthesis. And then just after 2 weeks the surgery, we're able to fit the definitive prosthesis on. And you can see here the bite is adequate, is even. And that's the post-operative X-ray. Okay, so to conclude, are we there yet with a fully digital workflow? So when it comes to digital planning, it is scientific validated and clinical validated, same as in guided surgery. Now we have adequate and sufficient literature supporting that and clinical experience. CAD/CAM restoration are also scientifically validated and clinically validated, whereas with the digital impression are scientifically validated but only clinical experimental. So I would like to thank you all for your attention, and then if you have any questions or you want to reach me out to connect with me, and please feel free to add me on Instagram or to Dr. Clozza. This is my account, my professional account, or email me directly on emcreferralslimited@gmail.com. Thank you very much.